very important to those who want a CE, to collect your CE credit for today's presentation, you will be required to complete a brief survey. The survey needs to be completed by February 15th. The link to that will be on the last slide. It will also be emailed to you for convenience. Now you want to enter that into your browser, and this will take you to the survey. Your CE will then be emailed to you after the survey is processed. So it may take a few days to receive the certificate after completing the survey. Thank you again for your participation in this exciting webinar. Our presenter today is Dr. Gregory Shears. Many of you on this call know Dr. Shears from his valuable work in the vascular access arena and with professional nursing organizations like AVA. He is well respected and is highly sought after to speak. But for those of you on the phone who don't know Dr. Shears, he is a pediatric intensivist and anesthesiologist with a long-standing interest in reducing patient complications and improving our approach to vascular access. He did his pediatric residency at St. Louis Children's Hospital, his anesthesia residency, pediatric anesthesia fellowship, and pediatric critical care fellowship, all at Johns Hopkins. He worked on the Children's Hospital of Philadelphia for 5 years and was recruited to the Mayo Clinic in 2001 to head the ECMO service. There he is professor of anesthesiology, the physician liaison to the nurse-led PIC team, former medical director of the ECMO service and co-director of the congenital heart unit. He has served on the editorial board for JAVA and on the AVA board of directors as treasurer. He is very active in the development of medical devices to help reduce patient complications. Dr. Shears has given hundreds of presentations locally, nationally, and internationally. So with that, let's turn the program over to Dr. Shears.
Thanks, Bruce. And greetings from Rochester, Minnesota. It's a balmy day here. It's been getting warmer. We're up to 16 degrees Fahrenheit. That's -9 degrees centigrade for those of you that don't use the English system. And it's actually a beautiful day, even though it looks a little bit gray. We just had a modest-sized snowstorm. We got about a foot of snow 2 days ago, and these are views from my just outside my house, and you can see our deck and some of the snow piled up. And it was a sticky snow, a wet snow, so it clung to everything, which really makes it kind of a beautiful scene. It's sort of nature's way of creating a visual asepsis from the dreary, the brown of this time of year to making everything look kind of pure white. And just the last photo, you see this, some of the boughs of our pine trees breaking under the weight of the snow. So anyway, kind of an interesting view. So if I sound giddy or a little goofy, it's because I'm post-call. I worked all night, and I'm well caffeinated right now, and the good part is I'm getting to talk about my favorite thing, which is vascular access. And the topic, as you saw, reducing peripheral IV catheter complications and informing clinicians, technology, and the 5 Ps. As you all know, vascular access clinicians are the unsung heroes of medical care. And we often, there's an expectation that we do our job well. People often don't notice us. We know when we've done a really good job, and sometimes the patients that come into the system frequently recognize our skills and how we do things better. And we as a group take pride in what we do and continually try to make patient care the best possible. And I found, even though I've really focused on this area through my life, through my various training, I still find to really have an edge to need to incorporate technology into my practice. Difficult vascular access is becoming so commonplace. Some of my time last night as I was managing a couple ICUs, included having to start access on difficult patients. And I would have been lost given that there were no visible or palpable veins with just using my eyes and fingers. And without technology, I would be placing a central line or something else. But I was able to place prolonged dwell peripheral IVs that will serve patients well, thanks to that added benefit of technology. So anyway, moving along, for the sake of disclosures, I'm a consultant, the relevant ones for this talk. I'm a consultant for B. Braun and Christie Medical, and I'm very grateful to them for supporting this presentation and letting me participate in this educational process. Objectives that I'm going to try to cover today include characterize some of the factors that lead to vein loss and peripheral IV catheter complications, to discuss efforts being used to keep veins patent and prolong dwell times and reduce complications, and compare the advantages and disadvantages of ultrasound and near-infrared technology that can help with this process. So first category I'm going to talk about is vein loss and peripheral IV catheter complication. I've used this paper a number of times in presentations. It's a really nice paper, and it provides a 25-year overview of all of the prospective randomized, prospective observational, and retrospective studies related to the incidence of failure for peripheral IVs. And basically, every single category shows that the failure rate is right around 50%, which is really quite remarkable. The rate of complications associated with peripheral IVs is unacceptably high. The name that the authors put on this paper is Accepted but Unacceptable, and I think it's a perfect title because we have grown to accept an amazingly high failure rate. We wouldn't accept this type of failure rate in any other area, and why have we become complacent that this is the status quo of vascular access, peripheral vascular access? You know, as you all know, peripheral vascular access is the most common invasive form of venous access that we have. Somewhere between 60 and 90% of all acute care patients have an IV. And so therefore, there's an opportunity for a lot of work to be done. And truly, we need to think about this problem in a different way because we continue to do the same old things and just kick the can down the road. And we've got to stop that and really look carefully at what we're doing and go in other directions. So, you know, for some reason, I'm having a slide advance. Oh, there we go. There, it wasn't advancing. So one of the tables from this paper shows some of the rates of the common complications. So those include catheter-related phlebitis, and on average, this is around 15.4% reported. Catheter infiltration, commonly reported in many of the papers, somewhere between 15 and 26%. This one they're calling an average of just about 24%. Catheter occlusion, mechanical failure, nearly 20% as a mean. And then dislodgement often shows up in the 6% range, infections being a fraction of a percent. So very topically, I'm sure all of you watch the news. I've become kind of a news junkie given how easily we can access it and how many different sources there are. Just recently, these sort of things almost never make international attention, but this is little Emmy from Edmonton, Alberta, Canada, who's a status post cardiac surgery for a congenital anomaly. and postoperatively developed an infiltration injury. If I read the article correctly, this was an infiltration injury, not an extravasation injury, and it was just a crystalloid-based fluid. But we all know that a compartment syndrome that can develop from the fluid can just as easily cause ischemia and injury. And so apparently ischemia, as you can see, to the back of her hand and blistering and whatnot across her wrist has led to sloughing, and it sounds like this has progressed. Fasciotomies have occurred, and the need for skin grafting and some potential loss of function and things. So a very terrible situation. We usually don't see this on an international level where it's out there in the news, but these things happen in our hospitals quietly and to varying degrees. I'm going to pause here a minute. Aaron, I see on my screen a lot of issues related to no sound. Are you able to hear me?
Yes, I can hear you. Unfortunately, I'm not sure. I'm not sure exactly where they're having the issues. They should be able to hear with audio. I do have some people that have told me that they are able to hear just fine. So it may be that they have not dialed in to the proper number, or their computer audio is not working. But it's unfortunately it's on an individual basis, so it's not easy for me to troubleshoot on that one. I would ask, Bruce, can you please, in the chat bar, go ahead and copy and paste in the dial-in number? People may be trying to do that on their computer, and maybe the phone audio would work.
Also, just Aaron or Bruce, if you can cancel out all of the for whatever reason, all the announcements are coming up on my screen too. I'm doing my best to avoid looking at them, but it's distracting.
Let me see what I can do. I think that's something where you would need to unclick the chat that's at the top, and then that should hopefully do it. But let me see if I can turn that off. Sorry.
Okay. So anyway, getting back to a very unfortunate situation. I spent a lot of my time in the cardiac ICU. As a matter of fact, I was there last night, and these patients that are at the extremes of age, those that are sedated, those that are critically ill, are particularly vulnerable to these sort of injuries. People are quick to blame the bedside nurses on these things, but the truth of it is, and I've thought a lot about these sort of injuries, they're extremely difficult to pick up, particularly with the workload that nurses have nowadays. They can happen quickly. So it's another opportunity for technology to help us both with picking optimal sites and also with monitoring. Both are readily available to help reduce or avoid these kind of complications. So next slide is an article that comes from the Avatar group, Claire Ricard and their amazing Australian group. Everybody should take the opportunity to read things that come out of their group, because I found it always of high quality. This particular paper, I think, came out 2 or 3 years ago, and was a repurposing of their original paper from back in 2012. If you recall, they've written a fair bit about the topic of routine versus clinically indicated replacement of peripheral IV catheters. And they did a very nice prospective randomized trial. They had something like 6,000 total peripheral IV catheters. I think it was almost 4,000 patients. So it was really a mega data collection, multivariate, et cetera. And so they had reported that there's been, Cochrane data analysis, and then they repurposed the data for this article that looked specifically at risk factors for peripheral IV catheter failure. If you look at the cast of authors, I think there's a nurse or two and 4 PhDs and 1 physician. A pretty heavy group, pretty talented group that is looking at this large data set. So anyway, I have put the averages up there of what they came up with for occlusion, accidental removal, and phlebitis. A couple interesting things or things to note from this data set. Under occlusion, they had a bit broader definition than we might typically have. And under occlusion, it's not just thrombosis or just catheter kinking, but also infiltration, extravasation, injury would fall within that category. Accidental removal, very similar rates to what has been seen in multiple other studies. And interestingly, phlebitis is amazingly low compared to many studies. And I don't know if that's just because Australians are a bit more stoic and don't complain, or they're doing something different or better than we are. I don't know, but it's interesting that the rate is 10% lower than typically reported. So anyway, some of the independent risk factors that they found, and I'm going to point you to the hazard ratio column, is that, and some of these things are things that we've known from other studies, such as peripheral IVs placed in the hand compared to the forearm are at higher risk. Women have a higher risk by 1.4 times. Interestingly, antibiotics infused through an IV, of course, depending on the one, I suppose, have a higher risk. I was surprised to see hydrocortisone being an independent risk. No surprise that the antecubital fossa is a higher risk. Upper arm, I was a little bit surprised, was a higher risk, but maybe their catheters are too short, and maybe they don't have an adequate purchase, and hence they're infiltrating, since that falls under their definition of occlusion. So anyway, some interesting data. Another interesting thing was that there was a reduced rate of occlusion events if an antipyretic was infused through the IV. So it provides pause to one that an additional etiology that one may need to consider as part of the process for failure. On this slide, independent risk factors for phlebitis, again, women being significantly higher risk than men, 1.6 hazard ratio, a larger catheter, not a surprise, 18 gauge compared to a 20, and then current infection and as being another. Age was not an independent risk factor, and other drugs infused through the IV actually had a lower risk. So again, this is the kind of data set, because it's of high quality and large number, that we should all sort of think about, scratch our heads, and generate hypotheses that could be tested to help us go down the pathway of better understanding cause and effect, and create studies to actually prove so in the future. So what does that ideal vein look like for peripheral IV access? We know from INS and those starred items with the red asterisk that we shouldn't put IVs across the joint, that it should be of adequate size, maybe not adequately defined, and then down below in the forearm compared to the hand and the antecubital fossa. All good advice. This is advice that has been given for a long period of time, and to some degree we follow that, though there are different camps that violate that commonly based on their practice requirements or their beliefs or other. Of course, we would all like there to be adequate support of subcutaneous tissue. Anybody that has placed IVs in geriatric patients and noted the almost absence of subcutaneous tissue and the failure of support of vessels knows how fragile the skin and vessels can be for the very elderly. We would love to have healthy vein walls, but we can't do much about it. We get the patients that we have. As best we can, we should try to pick straight venous pathways so that our catheters are not lying against curvilinear places that can cause problems. Ideally, we should not have any valves within the catheter tip. We should avoid, of course, placing catheters in or near thrombosed veins. We would like to know, does the vein have good venous flow? Since we would like our medications to be adequately diluted, and so if we happen to choose a vein of poor flow or we're crowding it with too large of a catheter, we may in fact bias that vein towards thrombosis or stenosis or ultimate loss due to some other mechanism. And then lastly, as I already mentioned, we should try not to have the tip near tortuosities and bifurcations. You can imagine if a tip is up against a wall and you're doing a flush, kind of like power washing the inside of the endothelium, or providing a medication that with dilution might not be toxic, but if it's concentrated against the endothelium may in fact cause endothelial injury resulting in thrombus formation and subsequent thrombosis of the actual vessel. So the non-start areas are intellectually reasonable assumptions, maybe not proven, but things that logic would suggest we should strive for in our current practice. So hence this presentation was created, Preserving Veins and Reducing Complications, the 5 Ps of Peripheral Vascular Access Best Practice. And I'm going to talk about these 5 areas that I think are essential to get us kind of out of the hole we're in. We're in a rut. We're in a 50% failure rut. And we must get out of this situation. And the only way that we're going to do this, I think, as I've really thought about this problem, is considering moving forward with these 5 topics. Pre-access assessment. We give lip service to this. We don't actually do it in its entirety, and we haven't grasped this concept for the power that it has to promote vascular access teams and make them not technicians but consultants. Technology can help us pick optimal sites, and I'm going to talk about that in a moment. We need to prevent thrombosis, and we'll talk about that in a second. Technology can help us with placement, and like I said, if it wouldn't have been for technology last night, there is no way that I would have placed a couple of the vascular access devices that I did, because it would have been physically impossible. And lastly, we have to stop thinking that veins are to be used. We have to think of veins as a valuable resource. We need to think in terms of vein preservation. We need to think of not what is the largest catheter we can place, what is the smallest catheter that we can place in order to do the job. That has to be the way we're thinking about this. So all very important, and we need to do this as a community. Unfortunately, this is one of those preaching to the choir bits, because probably just for the sake you've tuned in and you have an interest in this topic, but we have to help our colleagues as well and give super user presentations or whatever mechanism of education you have within your communities in order to get out the word of trying to reduce this epidemic that we have of the difficult vascular access patients. So the first category, pre-access assessment and device choice. for an ideal vascular access encounter, this is the kind of encounter we would like to have if we had to be hospitalized or we would like our loved ones to go through, and hence, if that's what we would want, that's the way every patient should be treated. We should provide pre-access assessment on every single patient, and I'm going to go into some more details about what that should be or what I think it should be. Part of that has to be taking a focused patient history around vascular access and understanding what the intended therapeutic goals are for their hospitalization or their medical encounter. We need to examine the patient and consider what options are reasonable. The only way we can do this is to understand how many viable venous targets they have. Otherwise, we're just shooting in the dark, and that's exactly what we do. We shoot in the dark mostly. We're just glad we get access and we walk away. We don't think about the patient's future. That's wrong. So, and then we have to educate and partner with the patient. Patients are so smart these days. They have access to so much information. We've lagged behind significantly in the vascular access realm, but we're always stronger when we partner with the patient, educate them about the options. They can help us to make good decisions for them based on their lifestyle and things related to what sort of options they have. We then select that optimal form of vascular access and place it using best practice. And hopefully, their course, by following these best practices, they have an uncomplicated course, they're happy, we're happy, everyone's satisfied, and we start to knock away this huge dissatisfaction that exists related to vascular access encounters and phlebotomy. You know, it's been a consistent dissatisfier for patients for well over a decade, and it's something that we really need to address. So my hat's off to Marcia Ryder, a brilliant lady. You know, we've, this last year at AVA, the 2017 Congress, we awarded her the Suzanne Laverne Herbst Award because of her amazing achievement. She's an incredible educator and scientist. And I didn't know until recently that she was the first one to come up with a vascular access device selection algorithm. And it, you know, given how complicated or how sophisticated she thinks about the world, you can see at first blush this looks a bit on the complicated side, but actually it's got all the components that subsequent algorithms have in it. And then there's been multiple algorithms that have generated from this initial work. This is the first one I became aware of back in '98. I saw this shortly after it came out in press, and it was from the Denver Health System, and it shows the power of a quality review process that was done, 371 patients, and they had a lot of interesting data that generated from this paper. And the thing that's true of all of these algorithms is that they are based on the fact that you have to assess vascular integrity. Well, what the heck does that mean? My assessment of vascular integrity is going to mean something different than yours. And we don't have a common language, and this is part of what is hampering the process of advancing the science of this. We need to develop a common language. We need a common metric that we can all agree upon to say, okay, this person is truly a difficult access because here is how they are graded. There's been effort, good scientific effort based on scoring systems that are predictive models. And if you stop and think about that, yes, they're scientifically interesting, but at a given point in time when you have a patient encounter, a patient that's difficult one day, or let's say easy one day, can be quite difficult the next. Patients' conditions vary due to multiple things: level of hydration, skin temperature, you know, how the clinician skill, you know, so many different things, and I've addressed this issue in a prior presentation. So we must have a common language around which we grade these people. And this is just an even more modern version from another incredible person, Nancy Moreau. And again, vascular integrity assessment precedes the device selection. I will tell you that with the help of technology, it completely changes the ballgame, because whereas what you see with your eyes and feel with your fingers may lead you to believe this person is an impossible peripheral vascular access, with the aid of technology, suddenly they may become quite easy and trivial to get peripheral access. So again, there's a need for us to really better define what the heck we're talking about, so as a research community, we can truly develop protocols that we can that have meaning across different institutions. More and more people more and more groups are paying attention to this issue. A number of companies have really nice information on their websites and different programs, Assessment Advantage Program, Vessel Health, Assess Pro, and the Registered Nurses of the Association of Ontario have a really nice thing on their website as well. So all nice resources out there that we can go to and think about how different groups are considering assessment. I recommend all of you to try to go to these sites, look at them, get ideas, see how we can all move this forward. So as I said before, one of the big problems is a problem of implementation because we're stymied at the very beginning. We have no standardized method for screening. We have no standardized means of quantifying difficult access versus the number of viable targets. I say this commonly nowadays as a thought problem. If you have a patient with a huge cephalic vein sticking above the skin, one of those really juicy ones that you want to just put an IV in, and that's all they have for peripheral venous access, no other veins. Is that patient a difficult vascular access patient? If I didn't ask the question, I think very few people would not go place a catheter in that vein and walk along and continue to do their job. We're busy people. We have a lot of things to do. But did we serve that patient well? They have a single vein. Should we be preserving it? Should we be thinking about what is a minimal number of adequate viable veins in the periphery we should try to preserve? Should we have considered a midline or some other thing and preserve that peripheral vein? These are topics we need to understand. And the problem is we don't have a prospective sense of the natural history of these veins. We know the end result from the chronically ill. You look at them and they'll tell you, you ask them, what kind of veins did you used to have? And they'll say, I used to have all kinds of veins, but for a given hospitalization, I've been stuck 10, 12, 20, 30 times, and I have no peripheral veins left anymore. So we've got to think about vascular access is how many viable venous targets do they have and manage them that way. And we need to create cutoffs and not do it like we're doing with the earth. Let's not burn down every last tree and then wonder where the oxygen went. Let's try to be proactive, and let's try to think about, okay, we're going to manage this prospectively, try to preserve viable targets, and then have cutoffs in which we're going to implement different venous access devices. So we must incorporate modern technology and current practices, and we need a scoring system that promotes communication and research. So here we have just a little video that keeps rerunning, and it's a lady that I'm doing a visual assessment on. How do we quantify this? In this case, I suppose it's easy. I can't find anything. I'm looking all around, and I cannot find any peripheral vessels readily with my eyes. And so now I'm beginning to palpate on this patient, and how do I quantify what I'm finding? I might feel something here or there. How can I write that down? How can I communicate this with somebody else? So next, ultrasound. Now, ultrasound provides a really good window into what is below the skin. I've been using ultrasound for every central access since 1996. And I've been using it for difficult peripheral access since 2001, you know, back when the screens were teeny tiny and you could barely see the veins on it. So it's a great tool. Everybody should be proficient at it that's serious about vascular access. But as a screening tool, not so useful. You know, it's you almost have to dip the arm in gel and kind of look around in all places to try to then quantify, well, how many vessels do they have, trace them out. It's rather slow. It's doable, but it's just not quick. And so it's possible, but just challenging to do it in a time-efficient manner. So that's why, by default, I have come to believe that near-infrared as a screening tool makes so much more sense. I'm moving the device here slowly so that those of you that get motion sick when you see video don't do so. But literally, it's as fast as you can move the thing across the arm. You can get a sense of how many viable venous targets a patient may have. You can take pictures with some of these devices. So you could actually record it. And, or you could do a group categorization of the number of viable vessels very quickly as a count and categorize it as a range. And here's another video with just focusing on a single patient as I'm screening back and forth. It's incredibly helpful for both venous access and phlebotomy for me because, you know, a lot of times, for example, with phlebotomy, you feel, or access, you feel the sponginess of a vessel. You're not totally sure the directionality of it because you only see or feel a small segment. So it helps give you some direction and helps you plan your angle and direction of insertion better. So many advantages and many things to talk about, which I'll go forward to. But the point here is the ease and speed with which one can screen. Nowadays, I use this all the time. It makes me very efficient because I grab it and I do a pre-access screening. So I know what I'm getting into, I know where I'm going to go, and then I get down and focus on that. So I'm not just hitting the first thing, I'm making an assessment of all of the viable targets and picking the one that makes the most sense. Sometimes, if I know a patient's at difficult access and I know that they only need access for a brief period of time, I might choose a vessel that somebody else isn't even going to try to go after, but I'm just going to, I'm going to choose it because I think that it'll serve the purpose of a day's worth of access, and they've got bigger, better ones that we could use and preserve for another time. So there's different ways that one can think about this process, but the main thing is we have to have in mind several issues, and one of them that has to be centered is vein preservation and understanding how many viable targets a patient has. So whatever we do, whatever we as a community decide to do, it has to be easy. It must allow point-of-care assessment because the patients vary from day to day, hour to hour. So we must have a real-time point-of-care assessment of their difficulty. It's got to be practical and fast. Every day, you know, they ask us to do more, run faster, jump higher, do more things. So it can't be some long, drawn-out activity. It must conform with our current best practice. It must have some kind of a scoring system that makes sense, and it'll need to be validated and applied prospectively. I propose the following. It's very pragmatic, and it has to do with how we approach the patients anyway, which is we begin with our basic skills, V category, veins that are easily located by sight. T I use for touch instead of P for palpation because I use P for pediatrics, different application. So touch T, easily located accessible veins by palpation. N for near infrared, easily located using near infrared. U for ultrasound, and then 0 lacks adequate peripheral veins by any of the above assessments. And we would choose the highest category and assign a number of a quantity. And the quantification has to be quick and general. Just a quick assessment. They have greater than 10 optimal venous targets, 5 to 10 optimal venous targets, 1 to 5. If they have 0, they go down to the next category. If it's not visible, palpable. If not palpable, near-infrared. If not near-infrared, ultrasound. If not that, we're going to be central access kind of thing. And then we can also be further descriptive in terms of bilaterally left or right arm. And we could have a language of how we communicate. So a patient could be visible, bilateral, 1 to 5 veins, and if you adopted the ABC, the letter categorization, they would be a VBC, or if they were palpable, bilateral, 1 to 5 veins, they'd be a TBC, or if they, if neither visible or palpable was a category of any significant viable targets, but using near-infrared bilaterally, they had greater than 10 viable targets, they would be an NBA. So it would be a way that we could, again, communicate with one another, categorize patients. We could even, with the help of the near-infrared, do photos. And so we could begin the process of understanding the natural history of what we're doing and try to find clues of how to better preserve veins. So we must do, I believe, a viable target assessment. We must do some direct visual, the direct visual and limited palpation assessment is impractical. It seems like, at least in my practice, it is grossly inadequate much of the time. Ultrasound is messy, slow, and hard to do over large areas. Great for doing access, not so good for the screening. So by default, near-infrared is the only practical approach that allows a timely, comprehensive peripheral venous assessment. That's just the reality of it. Second, picking an optimal site. And I'm going to have to speed up because I get so chatty, especially when I'm sleepy. INS has told us that smallest gauge is preferred. Good advice. Don't put it across the joint. Good advice. And try to pick a forearm. This is advice that has been going on for quite a while, and it's all good advice. They've also suggested most distal site because we end up burning up veins, so we should start distally and work proximally, avoid below prior insertions, and try to use larger veins. So again, all good advice. But the truth is that we've been doing, we've really, those of us paying attention to these good recommendations, we've been doing these things and we have not impacted our failure rate. It remains appalling at 50%. So, as Albert Einstein said, insanity is doing the same thing over and over again and expecting different results. And that's exactly what we're doing with peripheral venous access. So we need to really focus on some of the outcome factors that we can impact. And for the remaining of the presentation, we're going to talk about site choice, tip location, and catheter to vein ratios. It's my belief, and I've thought about this problem a lot, if we're going to advance peripheral IV catheter insertion and reduce complications, we must embrace technology. We must do things differently than we have been, and we must better understand the intraluminal relationship between the catheter, catheter tip, and other structures within the vein, such as tortuosities and valves. So how can we do this? So in the left-hand column of this table, the ideal vein, we know, not across the joint. Well, we can figure that out with our eyes easily. What about vein size? Well, ultrasound and near-infrared can do both of those things. You can get a sense of that. Sometimes with ultrasound, incredibly accurately. Near-infrared, you can do it very easily. A couple of the devices give an exact back projection of the vein size. Straight pathway. If it's a superficial vein above the skin, you can see it, but oftentimes not. Ultrasound, if you can have one eye on the screen and one eye on the skin, you can get a sense of it being a straight pathway. But with near-infrared, it's back projected right on the skin, so you can easily see it's a straight pathway. Avoiding valves. With typical ultrasound devices, it's very hard. to see valves in the periphery. With near-infrared, it's as easy as milking the vein and watching for refill. If you occlude distally with your finger, milk the vein, and watch for refill, you will see exactly where all the valves are, and I'll show you in just a second. Identifying obstruction. Ultrasound is good for that if you know how to use Doppler flow, and near-infrared is great for that. Again, if you just milk the vein, you can see if there's any filling defects or if there's a lack of filling at all. Venous flow, you get a really good sense of that. If you don't put a tourniquet on and you do this milking, you can see how rapidly the vein flows, an excellent rapid way. And catheter tip to valve, again, easy with near-infrared. So, again, by default, not seeking to have this as my conclusion, but by default, near-infrared has the checks in all of these critical categories. So it ends up being, in my mind, a no-brainer as a device that we need to incorporate in our daily practice. Even if we don't use it for the actual insertion, we should use it for assessment and identification for optimal sites. So typical patient, want to start an IV in. If you would have just gone after this, some of these veins that look a little bit juicy, not great, but not terrible, you would be in for a bad day, both you and the patient, because this patient has numerous valves in these veins. So here's an example, a little bit of video. And with simple milking, distal occlusion and milking of the vein, you can see exactly where the valves are. So where the blood stops the refill of the vein there, that is the location of the valve. It's shown with two different contrast modes here. So what other technology in a fraction of a second can you identify valves that fast and hence plan your sticks and avoid hitting them? So, and what about veins like this where you can palpate them, you can't really see them very well? If you would have gone after that one, you would have nailed a valve potentially right there. As quick as you can swipe your finger on the skin, right there is the valve. It's just such a no-brainer. It is so easy. Why don't we just do this? I think it should be an absolute requirement. So have you ever blown a vein due to hitting a valve, caused more pain to a patient from hitting a valve, requiring a second stick? Had an IV pump beep incessantly because the IV catheter tip bumps up against the valve or some other obstruction, or have reduced flow from gravity from the catheter tip being up against some obstruction like a valve? If you didn't answer yes to every one of those questions, you aren't actually either paying attention or starting IVs, because this is such a common problem. Here's a little cartoon I created, again, in the middle of the night, so I'm not going to say any more than that, other than here the catheter strikes the valve apparatus, causes a hematoma, and losing that as a site, causing pain, requiring a second stick. So not an uncommon scenario. So with identification of valves, you can much better plan where you're placing your IVs. Hence, choose optimal sites. You identify that your valve is there. You can keep your catheter tip at least 5 millimeters away. You can manage your J-loop on your extension set, and everything's good. You have no obstruction of flow related to your catheter. You can keep it away from the joint and really have a more sophisticated approach in terms of how you're choosing your IV access sites. So I'm having some misbehavior here from some interface, so hopefully this will spin forward. I don't know why it's doing that, but it's always interesting when you do presentations how technology can also get in your way. But for some reason it's binding up here. I may have to do a restart. So bear with me just a moment, since it's not automatically moving forward. I tell a funny story. I was once giving this really intense presentation at the time when I was transitioning to from glass slides to computers, and I hadn't quite made the jump. And I got caught with this really fancy slide projector that went into a seizure and just spun my slides incessantly. And I was speaking before about 500 scientists on some research that we were doing, and I had to do everything like hand puppets, make gestures up on the screen and things like that. So if I can manage that, I can manage anything. So here we're back. Valvology, hopefully you can see the slides again. Valvology is a made-up name. Valves are well known to interfere with optimal peripheral IV insertion functionality. Very difficult to predict where they are. I've tried to look at some pattern. Every time there's a bifurcation, I guarantee you there will be a valve there. You never know where it is. It's often going to be at the bifurcation, but you will also see it along straightaways in an unpredictable place. Sometimes both valves coming into a bifurcation will be have valves. Rarely you can see them with the naked eye, almost never. Very difficult to identify with ultrasound, but near-infrared makes it extraordinarily easy, as I showed you, just by milking the vein. So again, by default, if you believe valves are a problem, they interfere with peripheral vascular access, it's really the only optimal way for picking peripheral IV positions with current technology. So it's very helpful. Again, even if you don't use it for the actual placement, you can identify where the valves are and hence try to optimize the catheter tip position. So picking an optimal site, we probably have to gravitate, if we're going to impact this incredibly high rate of complications, we need to think about finding those straightaways, avoiding valves, not like the left side where a catheter tip is up against a tortuosity or on the right up against the bifurcation or a valve, but keeping away from those situations, having it in a clear area, avoiding valves and tortuosities, and in doing so, I bet we will reduce our complication rates. Third, preventing venous thrombus. So don't you wish everybody had great big veins like this? That way we could stick. They're very juicy, but more often than not, we have barely visible or palpable veins or nothing. This is so common these days that, pre-technology, these would be blind stick patients. And this gentleman said he never had an IV with less than 3 to 5 sticks. It's always at least that many. So a terrible thing for those patients with difficult access or high BMI. So Rudolf Virchow, a brilliant German scientist from the early 19th century, lived from like 1820 to 1900, taught us so many things. But relative to this talk, taught us about his, created this idea of a triad, the things that promoted thrombosis. Actually, he coined the word thrombosis and the word embolism. And causing thrombosis, you need 3 things. A vessel wall injury, which of course happens every time we do access. Hypercoagulability, which is very common with our sick patients, particularly if they have an ongoing infection or other things. And then lastly, stasis. And we create the stasis state by overcrowding the vessel with larger catheters than the patient needs. So unfortunately, as is true with much of our specialty, there's a limited amount of data. And so the risk of thrombosis with this PICC line study increased once the catheter-to-vein ratio was greater than about 45% of the catheter size relevant to the vein diameter. There's been some lab-based studies by Tom Nifong and others looking at reduced flow for flow pathway obstructions of various sizes. And based on this data, it's suggestive that closer to a 30% luminal obstruction or something within that vessel reduces flow. And so conventional wisdom currently is thinking, we should probably be at a catheter to vein ratio of, 1 to 3 at the most 1 to 2, but probably if we can get away with a third of the diameter of the vessel, that would be better. So this cartoon that I've created, if we have a good catheter-to-vein ratio, the blood flow is going to go around and we're less likely to have an obstruction. However, if we stuff an oversized catheter within a vein, we're going to get sludging. We may be able to infuse distally, but around the catheter and behind it, there's going to be an obstruction. And whenever we cause a thrombosis of a vein, we know that some percentage of the time, seemingly a relatively high percentage, it doesn't recannulize normally, and that vein's going to be lost, or it's not going to be the same integrity that it was before, and hence we march down that pathway of iatrogenically creating difficult vascular access. So how do you judge vein size anyway? You know, okay, here we can palpate something underneath the skin. What is the intraluminal diameter? Truth is, we have no clue. You can't really judge it. So if you pop on near infrared, you get an exact back projection of what the intraluminal diameter is. That is going to be that center dark spot that you see. There's kind of like a fuzzy outside part. You can see that little black arrow there, and that purple arrow there, or the blue, purple bluish arrow is pointing right on the edge of that darker side. That is the exact intraluminal diameter of that vessel. So we can place a catheter over the top of the skin and get a sense of the relative size, the catheter-to-vein ratio with direct inspection, and try to make a judgment of what the optimal catheter would be if we're going to try to preserve veins, which we should. So optimal catheter-to-vein ratio, difficult to estimate with the unaided eye. Palpation, essentially impossible. Ultrasound is very good at judging the size of catheters, but hard to know straightaways. So near-infrared gives you a combination. You can see straightaways, and it projects the exact vein width with some of the products. Therefore, near-infrared, in my opinion, is necessary, absolutely necessary, if we're going to do optimal peripheral IV to catheter vein ratio strategies to try to preserve venous flow and integrity. So we can't just look for straightaways and avoiding the obstacles. We have to find veins of adequate size. Getting close to the end here, and I apologize for being so chatty. The fourth category, placing a short peripheral IV. I hope all of you are avid ultrasound users and that you are getting the bug that you need to use near infrared. I know that it's still a growing technology. People haven't fully embraced its value, and I'm hoping that you're kind of getting the idea here that there's a lot more to it than you realize. They're complementary technologies. They both add. I use both regularly. You're not going to be at the top of your game with just one or the other. You have to work towards being an expert at both. Both can assist with the process of access. And as I've shown you, near-infrared has the additional ability to screen for viable targets, identify valves, and judge catheter-to-vein ratios. So please consider embracing both technologies, and each has a learning curve. Ultrasound can be a bit steeper, particularly for peripheral venous access. Here's that gentleman I mentioned before with a really high BMI who said he was an impossible stick, and he typically had at least 3 to 5 sticks. This guy just about cried. He couldn't believe that, one, how this technology worked. They just put it on his skin, saw the vein, boom, put in an IV, walked away. I mean, I was done in seconds. And he was shocked that he got a single stick. He was about to hug me. It was really neat to see how happy he was when things can be done better. The other thing is, it's very common that we palpate veins or see parts of veins that we get in the skin and we totally lose our way. And then we get into the finger sewing method of vascular access, oftentimes in which it is not successful. So the thing with near-infrared is that you can see as you're advancing your catheter what the vein is doing. And the reason we miss is more complicated than just what we think it is. For example, here I have just a catheter without a needle. Now notice how I'm pressing on the superficial vein, and notice how I'm moving it to the side. You can see to some degree that the vein is crushing a little bit, narrowing. I know from all of my central venous access, as I've watched myself do central lines in patients that don't have tourniquets, that the lumen can crush down significantly, especially if your needle is maybe not as sharp as it should be or the angle that you're going in is not quite good. Well, here you can see that the blood in this vein is completely collapsing. So the vein walls are, even though the tourniquet is in an optimal position, the filling is not such that a lumen is maintained. Hence, very easy to do a through and through puncture, and if you didn't prick and hit the lumen just right here, you would have a hematoma. So that's going to be one of the causes of access failure, and you can see it directly, though, with near-infrared as you're doing this. So it gives you so much more information than we typically have. The fifth and final category, preserving the integrity of the catheter site. There's, as I said before, very limited data on the natural history of access veins or attempted access veins. We don't follow patients prospectively, and I'm hoping that people with money and research resources can do that. Maybe the Avatar group can add this to their collection of all the great data they collect, where we prospectively gather data on veins, look at how often they recannularize. Experience with the difficult vascular access patients, the chronically ill, suggests that incremental target loss occurs in the peripheral and central vessels through repetitive access and injury. So iatrogenically, we cause injury through poor site choice, hitting valves, bifurcations, infiltrations, all of that. Vessels thrombose from oversized catheters, medications that we provide possibly in veins that have too poor a flow, maybe injuring endothelium, and maybe, you know, I think we think with regard to vessel injury too black and white, and we don't consider that. The reason we get away with some of these medications centrally is that because of the high cardiac output, many drugs become diluted. So if you have very sluggish venous flow in the peripherally, you may have some medications that would be normally fine peripherally end up being more toxic to the endothelium because they just hang out longer and have an opportunity to interact locally with the endothelium. So also, of course, poor catheter stabilization can contribute to vessel loss, though really we've dramatically moved that ball forward, and then I think from what I'm seeing, people are using better and better forms of catheter stabilization. So in summary, pre-access assessment is absolutely necessary to quantify viable venous targets and then enter into device choice algorithms. We must identify optimal site choices to help reduce obstructive and phlebitic complications. We need to pay attention to the catheter to vein ratio to help reduce thrombosed veins. And I believe if we begin to seriously address these issues, we're going to finally have an impact on this horrendous high % failure rate that we have with peripheral venous access. So I want to thank you so very much. I apologize. You know, I could do this all day, but I do have to go lay down. I've got to go back and do shift tonight. But I want to thank you for those of you that have tuned in. I know we had a substantial international audience today, I was told. And thank you all for tuning in and listening. We share common interests in this area. Please feel free to email me with questions and things as well. And don't forget, for the sake of getting your CEs, to go to this SurveyMonkey site and do what you have to do to fill out the survey. So again, thank you all very, very much, and I'm happy to answer any questions.
Thank you so much, Dr. Shears. And also, just so that everybody knows, you will get that survey link sent to you via email a couple of times. The WebEx site will send it to you, and then we will send it to you from Christie as well to make sure that you have it. And then you just need to make sure that you fill out that survey by February the 15th in order to receive your certificate, and the certificates are typically emailed out right after that closes. So I know that we're a little bit over time, so I'm just going to address a couple of the questions that came up, and then any additional questions, what we usually do is that we get answers from Dr. Shears later, and we provide them on the website and via email to all the participants. So just a couple of questions. Here we go. So Dr. Shears, are there any suggested protocols available that outline when to use near-infrared and when to use ultrasound?
There aren't. So thus far, the professional organizations that we look to for direction, such as AVA and INS and things like that, they, so for example, within the INS guidelines, they suggest, there's a suggestion of using it. There aren't specific protocols yet. My operating protocol as I go about my practice is I begin always with assessing with near-infrared, just because it's so fast to look at optimal targets, and then I fine-tune. I get down then and, what do I have? What are the numbers? And then do I have viable targets using that? And, of course, visual inspection can be very fast as well. And then I'll dive further. If I don't see anything there, I'll jump to an ultrasound assessment. And so I'll go down. But I personally always begin with near-infrared, just because of all the additional valuable information that it gives me beyond eyes and fingers. But I've not to date seen any, accepted protocols per se. It's in the development process. I know Ava's working on some things. I had to bow out of that process just because of having so many things to do. But they're working on some things as well, and I'm sure there'll be some smart people putting together some things from there. Great.
And we'll just do one more question because I know we're pretty well over time here. So this is a simple one. Does near-infrared technology work on NICU patients?
Yes, it does. Now, I have done a lot of NICU in my day. I'm an old school guy, so when I did my pediatric training, there weren't limitations on the number of months that you spent in the NICU and other things. They didn't believe in primary care back then. And so I think to my benefit, I got to do a lot of NICU and subsequently, as I was going through my training, moonlit quite a bit in that area. They're almost another organism. They're so challenging. It really, technically speaking, when you're trying to get access on a 500-gram patient or a 1-kilo patient, we're talking you're dilating their vessels with the catheters, and so you have to be a sharpshooter. And technology helps for sure. The smaller the vessel, the resolution of various things like ultrasound, it's hard to steady and poke and do that sort of thing. With near-infrared, the resolution is amazingly good, and it will allow you to see things that you cannot see with your eyes. But remember that the technology, whether it's ultrasound or near-infrared or whatever, doesn't put the catheters in for you. It just shows you the targets. And that's it's a funny thing. People blame the technology. And, if you couldn't hit that vessel with your naked eye, you're not going to suddenly hit it with an ultrasound or, of similar size. It just allows you to see what's there. It gives you a lot of additional information. Like I said, you can find valves and, be more strategic about your placement. But don't blame the technology for the miss. The technology is showing you what's there. It's that the problem has to do with the choice, the size of the vessel can be so small, it's just hard to nail it dead center and get it to advance. So I suggest caution with regard to choosing the biggest vessel that you can and kind of going from there and being patient. You're going to be thinking, boy, I can see all this stuff. It's just so easy. But in fact, there is a learning curve. People always say, well, that you can't judge depth with it. Well, truth is, the veins exist in a limited depth. In an adult, it's not going to be on the arm. It's not going to be any deeper than about 6 millimeters. You've got to go directly over the center of the vein. You have to have the thing positioned 90 degrees parallel to the skin, 90 degrees over the site, and then so that there's no parallax issue or other things. Make sure that nobody's dropped it and knocked it out of alignment. That's a rare event, but it can happen. And then go down the exact center of the vessel, and you eliminate one of the dimensions then, because if you enter just like you would normally enter any vessel, and you know approximately the depth, for example, with a neonate, where the vessel is going to be, that's where it's going to be. And you gently advance into the catheter just as if you saw it on the skin. So that's the way you have to think about it. One of these days, maybe we should do a webinar on sort of an advanced practice with near-infrared and all the tricks and things associated with it. So that, for those of you that have an interest, that's something that we could do. But it's valuable technology, but you have to, like anything else, be patient and learn and just spend time with it.
Great. Okay. Well, like I said, we're a good bit over time, so we'll go ahead and wrap it up and send any additional questions with the answers out to the participants at a later time. So I would like to thank you, Dr. Shears, as always. Really, really appreciate your expertise. And thank you to all of our participants around the world who signed on for this presentation. And we will see you all next time. So thank you so much.